In the next lecture, we're going to look at the evidence for FDG brain imaging in Alzheimer's disease. First thing I want to introduce you to is this model of the staging of Alzheimer's disease, introduced over 10 years ago. And really, you can see along the bottom axis that we see cognitively normal people, and then we have a stage called mild cognitive impairment, and then we progress to clinical dementia. And what we see, or the proposal in this model, which has turned out to be useful, is that very early on in the disease, we get the deposition of amyloid beta plaques. So these neuritic plaques that we talked about in the previous lecture. This leads to neuronal injury and dysfunction, which is the hyperphosphorylation of the tau protein within those long oxidative stress neurons, again, that we talked about previously. Only after those have become established do we start to see brain structural changes with atrophy, as those long axons start to die and we start to get synaptic loss. We start to see early memory changes as we lose those synapses. And then we start to get reduced activities of daily living as we progress into the more severe stages of the dementia itself. Now, there are other variations on this same model. So here we have pre-symptomatic, early mild cognitive impairment, late mild cognitive impairment and dementia. And people have also put in here the CSF alpha beta 42 protein and how that might change. Part of the JAK proposal is that we see FDG changes far earlier than we see structural changes, because we're imaging that synaptic loss and the neuronal death. And we see those changes earlier in posterior cingulate, and then into the lateral temporal, and then into the frontal. And within the MRI, we see structural changes in the medial temporal lobes before we see lateral temporal lobes and frontal temporal changes as we see that atrophy. So we'll keep referring to these models as we look through the evidence. If we look at pathological Alzheimer's disease and we compare it to the clinical assessment, then we start to see interesting things. For the clinical assessment, the positive predictive value of there being any dementia at all is high, around 81% in this study, and that's seen in other studies. But the positive predictive value of clinical Alzheimer's disease alone was much less than half, in those who were given clear criteria of Alzheimer's disease alone. And that many people had dual pathology, and this is what I want to be one of the take-home messages for you all, is that most patients have dual pathology. In up to 60% of patients have dual pathology, and we must be comfortable with that. If we look at the larger study of nearly 1,000 patients in the National Institute of Aging Alzheimer's Disease Centers over 5 years, these are the most skilled, the most well-financed 6 centers in the US. And their sensitivity and specificity was not good. their overall accuracy was about 70%. And this can be very important when you're starting to image with PET, in that sometimes the overconfidence of the clinician is not supported by the data. Interestingly, when clinicians said there was no clinical evidence of Alzheimer's disease at all, 39% of patients had pathological Alzheimer's disease, and that these investigators said an interesting thing. The misdiagnosis rate should be considered when estimating subject numbers for Alzheimer's disease studies. And this has been a real curse, I think, in the literature for Alzheimer's disease. So before we look at FDG as the dominant discussion today, I'm going to quickly talk about CT, MRI, and a little mention of amyloid PET at the end. So CT, most patients have a CT sometime along the course of management. Really it's there to exclude rarer pathologies, mass lesions. One thing I will say is that, and again I can say it to you because I've said it in front of the British Society of Neuroradiology, is that the neuroradiological assessment of atrophy is terrible. They assess it poorly, they describe it poorly, they define it poorly, and they do not consider it an important consideration. I think this is absolutely not true, and I'll show you how we may introduce that into reporting during today. So CT is really looking at quite advanced changes. So we're looking at brain shrinkage patterns, and so the green oval here suggests where we're looking at with CT scanning in imaging. So MRI is a much more common assessment than it used to be, again about excluding clinical pathology. It can identify ischemic changes, but again this is often dismissed by the neuroradiologist as a normal finding, an incidental finding, not important. And again, hopefully we'll try and convince you that that's not true. And again, I think exactly the same as we do about CT, that atrophy is poorly assessed, poorly reported, and I see this repeatedly in my day-to-day practice. So one thing I'm going to encourage you to do is really to adopt the Shelton's grading of medial temporal lobe atrophy. So this is graded as normal, grade 1, grade 2, grade 3, and grade 4, and has good accuracy. So what we are going to, so I'm going to ask you to go and review this and look at normal, early, grade 2, grade 3 and grade 4. And when we review some of the scanning, I'll show you how we can incorporate this into our reporting, which I do routinely. If we acquire high isovolumetric, high MAS, high quality CT component, then we can make these grading assessments as part of our normal practice. This is very useful, often in confirming a pattern of AD, in confirming an asymmetric pattern of AD, and sometimes in helping us to exclude AD as a imaging differential diagnosis in certain patients. So when we start to look at high quality MRI with multiplanar reconstructions and MRI and high quality CT with multiplanar reconstructions, we start to look at shrinkage in a more in an earlier phase of this staging of the Alzheimer's disease. So let's talk about FDG uptake within the brain and what FDG is how it might help us. So previously we looked at what it might be imaging and some of the fundamental components that might be imaging. But here we're going to talk about how the data, how those patterns, these simple patterns, are going to help us. So if we look at some pathologically confirmed trials of 138 patients, we can see that there's high sensitivity in this retrospective study for Alzheimer's disease only, slightly reduced sensitivity for all dementia subtypes, but still good detection of this, and but a lower sensitivity for excluding disease. And again, we'll talk about why that might be. So again, if we look at pathologically confirmed study, where we have looked at, or where these people have looked at 4-year clinical follow-up in 44 patients, so really long follow-up with pathological confirmation at the end. And what they show is that this initial scan is like looking into the future in 4 years' time. So the FDG PET-CT today is as good as the clinical assessment in 4 years' time. And this is one of the big advantages of imaging early in a disease. And we've already discussed about why it's important for people to get an early scan. If we keep looking at this same study, we can show that in PET positive patients, the clinician thought that it was clinically unlikely to be Alzheimer's disease in nearly a third of those who are PET positive. And in those who are PET negative, again, nearly a third were in the clinically likely Alzheimer's disease category. So this should support the idea that I'm going to tell you, and this idea is that you are better at diagnosing early Alzheimer's disease than the clinician. And in my experience, many clinicians find that quite difficult. So if we take the data from that trial, really what we're doing is seeing this early nerve injury and early disease and reaching forward into the future and being able to predict those patients who are going to develop significant disease. And I'll give you more evidence to support that. So in a study from Karl Herholtz in Manchester, showed that if we compare Alzheimer's disease and normals in large numbers, that the sensitivity and specificity and the overall accuracy in mild to moderate Alzheimer's and very mild Alzheimer's is very, very good. And my own analysis for some political work that we did shows that if you analyze 458 patient studies, again, accuracy of nearly 90%, London area under the ROC curve, which was very, very good. So again, this supports the idea that to distinguish AD from normal, we're doing very, very good. But of course, that's not what we need to do. What we need to do is use FDG to distinguish different types of dementia. And again, a good study from Lisa Mosconi showing that looking at 548 patients, that the accuracy of FDG to diagnose Alzheimer's disease, dementia with Lewy body, frontotemporal dementia and normals was very, very good. If we look back a little bit earlier in the patient cycle, so if we look at GP, in the GP setting, we look at 102 patients, and that we get the diagnosis of Alzheimer's disease correct about 4 times out of 5. So this is very good. in this context. And this is with clinical follow-up of 5 to 6 years. So positive likelihood ratio of an early scan in the early assessment of a patient of 4.1. So high negative predictive values with a negative likelihood ratio of 0.27. So again, we're doing very well looking at these things. If we look at the conversion of mild cognitive impairment to Alzheimer's disease, we see a conversion rate of about 1/3 of patients. And this is best predicted in this study with a combination of the neuropsychological testing with either hippocampal volume assessment, which is quite difficult to deliver in the UK, or FDG PET-CT, which is much easier to deliver in the UK. And just to mention that amyloid PET and CSF biomarkers didn't make a big difference in this context. If we compare FDG PET-CT patterns of hypermetabolism with other biomarkers in this group of patients, 97 patients from the ADNI group, we see that FDG PET-CT had the greatest prognostic information, and misclassification rate was reduced from 41% to 28% compared to pathology. So again, FDG PET-CT reaching into the clinical context and making a real difference. And in the Biomark APD project, looking at 80 MCI patients, that FDG PET-CT with the addition of SPM was the best predictor of conversion of MCI to AD. And I will mention SPM a little bit. So in my own analysis, again looking at studies involving 685 patients, again we see an accuracy just a little bit less than the distinction of normals from abnormals, but an accuracy of 85% in those who are going to convert from MCI to AD, and a very good area under the ROC curve. We might say what might be the impact of an early diagnosis. Some people do say people don't want to know, and that's not true. And they say if you do know, it doesn't make any difference, and that's not true either. So this was an early assessment of FDG PET-CT showing that the accuracy of FDG PET-CT, even if very reasonable, there was a 60% reduction in avoidable nursing home care and 48% decrease in unnecessary treatment. And this seems counterintuitive, but this is because if you give people the knowledge of their disease and you give them the ability to manage their own disease, then they start to compensate for these things and start to adjust for the presence of the disease itself. If we take it a little bit further and say, how about FDG PET-CT in the memory clinic itself? And here it led to a change in diagnosis in nearly 1/3 of patients, increased use of cholinesterase inhibitors, unclear diagnosis cut by more than half, and most useful in unclear and atypical cases. And this is a useful take-home message. That really once somebody has entirely typical established Alzheimer's disease or frontotemporal dementia, they don't need a PET scan. It's very clear to the family and to the clinician what the diagnosis is. Our job is really about imaging early patients in which it's uncertain what their diagnosis is. And I would say that I rarely image people with MMSEs less than 25. That would be unusual. Importantly, in this meta-analysis, we also see that with good sensitivity, specificity and accuracy of FDG PET-CT, there appears to be a close relationship between the severity of the appearance and degree of cognitive impairment and the clinical severity of the dementia. And we also know that the severity that you see today is going to predict nursing home attendance in the next year. And so overall, FDG PET-CT is effective and useful and is being incorporated into the biomarker evidence for the definition of Alzheimer's disease. And so the orange oval is showing that FDG PET-CT, again, reaching further and further back into this model of staging of the disease itself. If we quickly look at some pathological studies comparing, can you distinguish Alzheimer's disease from dementia with Lewy body? It's better than the clinical criteria with an accuracy rate in the mid-80s, so very good. If we look at the distinction of Alzheimer's disease from frontotemporal dementia, again we see accuracy nearly 90 and very good function of FDG PET-CT in this context. In this study and multiple others, if you compare FDG PET-CT with SPECT and MRI, it generally outperforms them. I would say if it's done well, and this is really what we want to encourage you to take away today. And if we, I want to mention SPM analysis. And so SPM analysis is something that I'm not going to show you today. And that's because we want you to clinically provide a good quality service and in a detailed way, and we'll show you how to do that. But there is evidence that SPM can help. I think SPM can be a useful adjunct, and in this study it correctly identified those converting from MCI to Alzheimer's disease or frontotemporal dementia. But overall, I think it's a bit like the cardiology, polar plots and different things, that these things can be useful, but usually when you're uncertain, they're uncertain. And but it can be a helping hand early on in your practice. But again, as this review indicated, you must be aware of the problems of heterogeneity of these tools, their complexity and how they might under and over-interpret things, and the drawbacks to them as well. I want to just quickly mention amyloid PET. We're not really going to review that a lot today, but I think it's worth mentioning. The addition of amyloid PET in this trial improved the prediction of deterioration over a year and a half for both the clinical and the FDG PET services. I've been involved in amyloid imaging for many years, and it remains a disgrace that this methodology is not freely available to us as clinical practitioners. So really, amyloid PET is really predicting the presence of moderate to frequent plaque density as part of the defining pathology of Alzheimer's disease. If you remember one of the other previous slides about the CRAD criteria. And importantly, if we look at all amyloid agents, about a third of patients who are normal cognitive individuals show a pattern of amyloid. But again, this is important because you don't want to do any test on anyone that's not useful. And that, I think, applies to all medical tests. So, and we've seen with the JAK staging model that the fact that people are amyloid positive and cognitively normal is not surprising. But if we look at PIB studies as one of the early amyloid PET agents, that it does appear to increase if you do serial imaging in people. So we're imaging early on, but we also see some increase in patients who are already developing symptoms. So maybe this lower model is slightly more accurate than the JAK model, but that's quite difficult. So this is really just to show you this blooming of tracer activity that we see. So the one on the left is the normal, where we see this maintenance of grey-white matter differentiation, and then we see this blooming, this tree in full leaf kind of appearance. So really, I think plaque imaging, the amyloid imaging, has utility across the whole. And if we can convince people to that this is that the diagnosis of this fatal brain disease is important, then maybe we can get funding approved for amyloid imaging. So we have lots of different imaging available in dementia. And as this review said, these modalities have different strengths and limitations, and they are often complementary. And certainly my direction of travel is in FDG PET plus MR, so not a PET MR machine, I don't have enough money for that, but PET plus MR as a routine delivery, and I wish I was able to deliver amyloid PET more frequently. But again, I think this paradigm shift in the assessment of dementia continues, and so that's some of the evidence of FDG in Alzheimer's disease. And thank you for listening.